I'm Dr. Joseph Chebli. I'm the medical director of the bariatric surgery program at UW Medicine Northwest Hospital Medical Center, as well as at Evergreen Hospital Medical Center. I am a Center of Excellence certified surgeon by the American Society for Metabolic and Bariatric Surgery and the Surgical Review Corporation, both myself as well as my practice. And I'm also the chairman of the Medical Review Board for the Bliss Company. So tonight, I want to talk to you about the surgical management of morbid obesity. It'll be a PowerPoint presentation at the onset, and then we'll have plenty of time for a question and answer session to follow the PowerPoint part of the seminar. So I thank you for your attention. So let's get started. When we talk about obesity, we talk about this terminology, BMI, or body mass index. It's how we define obesity. Obesity is classified according to the BMI, or body mass index, and that's a ratio of one's weight in kilograms to one's height in meters squared. BMI 25 and higher is considered overweight. BMI 30 and higher is considered obese, or class 1 obesity. BMI over 35 to 40 is considered class 2 obesity. Class 3 obesity is BMI between 40 and 50. And BMI more than 50 is considered class 4 obesity, or this term supermorbid obesity. What are the indications for surgery, for bariatric surgery? Well, we followed the NIH consensus from 1991, and that defines that morbid obesity is defined as a BMI more than 40 or a BMI more than 35 with at least one what we call high-risk medical comorbidity. And that can be something like high blood pressure or type 2 diabetes or sleep apnea or lipid problems like high cholesterol. We also want to see the patients have met the following criteria to be considered for bariatric surgery: that they have failed the diet, that they are psychologically stable, that they have some knowledge about surgery and its potential outcomes, that they're motivated to be successful, and that they have other medical problems that do not preclude their survival from surgery. There are 4 major surgical treatments that have evolved both here in the US and worldwide, and they're all done laparoscopically, or what we call a minimally invasive approach. And they are adjustable gastric bands, the sleeve gastrectomy, the gastric bypass, and the duodenal switch. This is let's get started, and we'll talk about the adjustable gastric bands first. This is a picture of adjustable gastric banding, and this in particular is the lap band, the most commonly used band in the United States and worldwide. So what you see in this picture is a picture of the esophagus and the diaphragm, and then this is a picture of the stomach. And the band is placed just below where the esophagus and stomach join to create a small, what we call virtual pouch of stomach by using this band. And this is what's called a restrictive surgery, because the goal here is to create a small reservoir. And then we can adjust the band by accessing the port and tightening and loosening the band to suit the needs of the patient in terms of their weight loss, in terms of their level of restriction, etc. So this is our society's last statement as a consensus on about adjustable gastric banding. And that's that weight loss is about 50% at 2 years of excess weight, that the mortality or risk of death with the procedure is 1 in 1,000, that the morbidity or the potential for other complications is about 5%. There are strong advantages of gastric banding, and they are that it's a simple, relatively simple procedure to perform, that it's the lowest mortality bariatric surgery that we do, that we don't have to do intestinal reconstruction or intestinal bypass. So what we do is we maintain the GI tract continuity with banding procedures. Most of the procedures can be done where people come in and go home the same day. That's a same day type of procedure. If the insurance requires it, for example, like Medicare, that we can keep people overnight. And that there's a relative lower likelihood and incidence of serious short-term complications with banding. The disadvantage of gastric banding is that there's a higher statistical failure rate than the other surgeries we're going to talk about, that there can be long-term foreign body complications, such as erosion and and slippage, motility problems, dilation problems of the pouch or the esophagus, and tubing and port issues. And it can be a less effective procedure for people who have a BMI over 50 or have super morbid obesity. And there's a lot of attention to bariatric surgery and its direct influence on metabolism or hormones of the gut and of the fat. And the band doesn't have a direct alteration on metabolism. So that's a disadvantage. The lap band, the trademark lap band, was recently approved for body mass index patients in the US between a BMI 30 and 35. It's the only surgical treatment currently approved for Class 1 obese patients for a BMI 30 to 35. It was approved by the FDA, and then it was endorsed by our society, the American Society for Metabolic and Bariatric Surgery. Patients have to have at least one comorbidity, one of those other medical problems to also qualify. And since this is a new FDA approval, we don't have long-term data in this group as of yet. Next, I want to talk about the laparoscopic sleeve gastrectomy. So what you see in this picture is a picture of the sleeve, side by side the part of the stomach that we remove, and we remove about 80% of the stomach with a sleeve gastrectomy. And we leave this reservoir, and we maintain the GI tract continuity in this procedure. We leave this reservoir that has the configuration of a half moon, or some call it a comma shape. Some call it a banana-shaped reservoir, and that's the sleeve gastrectomy. So this is the summary of the third annual international consensus that was done on the sleeve gastrectomy. This was held in New York in December of 2010. The first one was held in New York in October of 2007. The second was held in March of 2008 in Miami. And these were surgeons that were submitted data, and we found that 295 sleeve surgeons combined for a total of 26,000 sleeve gastrectomies, with a mortality rate, risk to one's life, of 1.9 per 1,000. And that the sleeve was used primarily as a standalone or sole operation in 75% of patients, and 8% so far had received it as a staging surgery. The advantage of the sleeve is that you can have that limitation of intake of food, or what we call gastric restriction, without the need for a foreign body. Because the pylorus is preserved, there's no dumping syndrome like there can be in gastric bypass. It can be a very useful first stage surgery for people who have super morbid obesity, that BMI group more than 50. It maintains the GI tract continuity that we discussed already, and that there is a direct change in metabolism and a direct influence on those hormones that are in the gut and in the fat with the sleeve gastrectomy. The disadvantage of the sleeve pertains to the increased incidence of some more serious short-term complications. The leak rate, according to the third annual consensus for sleeve gastrectomy, is 2.5%. The risk of bleeding, 3%. The risk to one's life, 1.9 per 1,000. There can also be abscesses or pockets of infection that can happen after the sleeve gastrectomy. Gastroesophageal reflux disease, or heartburn, is a relative contraindication to the sleeve. Barrett's esophagus could be considered more of an absolute contraindication to doing a sleeve gastrectomy. It's the only irreversible procedure that we're going to talk about tonight. So once you remove that portion of the stomach, it can't be put back. There's a relative lack of insurance coverage for sleeve gastrectomy at this time, and there's still a lack of quality long-term data. That's data out further than 5 years. So next we'll talk about laparoscopic gastric bypass, which is a combination surgery, a combination of gastric restriction as well as malabsorption, which is a change in the way that we reconstruct the intestine to give the body a a chance not necessarily to retain everything that's ingested. Okay? And it's also a procedure that has a direct influence on gut hormones, as well as hormones from the fat. This is the society statement from a little while ago, and that's that the weight loss is about 65 to 70% of excess weight loss with the gastric bypass, that the weight loss plateaus at about a year to 2 years, and at the time that this study was released, the mortality or risk to one's life was about 1 in 200 with gastric bypass. And the overall risk of other complications was about 5%. The advantage of gastric bypass surgery is it is considered by many to be the gold standard surgery. What we mean by that is the statistical effectiveness of the surgery, as well as the improvement in the other medical problems that people have. Weight loss is rapid with gastric bypass, and there is that direct change in metabolism that can occur. The disadvantage of gastric bypass, again, has a lot to do with more serious short-term risks. Leak is about 1%. VTE, or venous thromboembolism, is about 0.5%, and that includes deep venous thrombosis as well as pulmonary embolism. The risk of bleeding of 2%. The risk of a blockage or an obstruction, about 2%. The risk of mortality, which we've now updated, at 2 in 1,000. And the malabsorptive part means that people have to take vitamins and mineral supplementation the rest of their life. And lastly, I want to talk about the laparoscopic duodenal switch. In the duodenal switch, you see something that looks familiar from the earlier part of the talk, and that's the sleeve reservoir. So that's where the sleeve came from. It came from stage 1 of the duodenal switch surgery. And then you have a much longer type of bypass with a much shorter common channel. So this is really what we consider to be what's called the malabsorptive surgery, where more of that food is not being retained by the body intentionally for weight loss. This is the society statement on the duodenal switch, that the weight loss is about 70% of one's excess weight. That at that time, the operative mortality or risk to one's life is about 1 in 100, and the morbidity with the operation or other complications about 5%. Long-term complications can include things like diarrhea, malodorous bowel function, vitamin, mineral, and nutrient deficiencies, and in particular, protein deficiency. The advantages of the duodenal switch is that statistically, it's an outstanding operation for people with supermorbid obesity, especially if you look at people with higher BMIs of 55 and 60. People lose weight rapidly. People have excellent weight loss durability. It very much changes the metabolism and has a direct influence on those gut and fat hormones, and people resolve their medical problems quite well. The disadvantage of the duodenal switch is the increased risk in the short term of mortality, leak, blood clot, bleeds, obstructions. There are quality of life issues and protein and vitamin deficiency potential problems. This is a study that came out recently in obesity surgery.